to be here today and grateful for the opportunity to speak with you all. Today I'll be discussing fertility and family building as factors in the disparities in leadership that exist within academic medicine. I'll touch upon existing research in this area, as well as our research on the topic and ideas to address the issue going forward. Our relevant financial disclosures includes a grant from the American Society for Reproductive Medicine Research Institute. And I would also like to mention that the presentation today is largely centered around those whose genetic sex is 46XX and who have ovaries they intend to use for reproduction. I'll be using words like woman and female, but the concepts discussed today can be applied to all those born with ovaries and have gender identities other than female and woman. In terms of objectives, I would like you all to walk away today being able to first, identify fertility and family building concerns as contributing factors in the persistent gender disparities that exist in leadership and faculty rank within academic medicine. And second, to describe different types of potential support for physicians through all stages of their family building journey. As a brief outline of today's talk, I will start with a background touching upon current gender disparities within academic medicine, fertility and family building concerns among female physicians, the consequences of infertility, and the presence of support or lack thereof. Then I will discuss our research and finally potential solutions going forward. So women are increasingly represented within medicine as the number of female medical students, residents, and faculty continue to rise. But despite this trend, pervasive gender disparities still exist within academic medicine. Although women make up more than 50% of medical school matriculants, they make up less than half of residents and only 28% of full professors. According to 2020 data from the AAMC, women account for 43% of medical school faculty, but only 21% of department chairs and only 19% of medical school deans. Women are also underrepresented both among residency program directors who are role models and sponsors for career advancement, as well as on editorial boards of major medical journals, which prioritize areas of research and determine which authors will have their work published. However, these disparities do not seem to be improving over time. The Kaplan-Meier curves shown here are from a 2020 cohort study published in the New England Journal of Medicine, which found that women remained less likely than men to be promoted to associate professor or to full professor, with no narrowing of this gap over time. So this poses a question: what is at the heart of these disparities? Although gender discrimination may be playing a role, are there other factors affecting women's career trajectory? And while the underlying reasons are likely multiple and complex, fertility and family building concerns among women in medicine remains an important and largely understudied factor. Female physicians face unique fertility and family building challenges as the duration and intensity of medical training forces women to make difficult decisions, balancing their family planning goals with their career. I'll address these unique concerns in today's talk, including delayed childbearing, higher rates of infertility and pregnancy complications, as well as documented low fertility knowledge amongst physicians. First, delayed childbearing is extremely common among women in medicine, despite the fact that nearly 85% of female physicians desire children. And while the average age of first birth in the United States is 26.3, the average age of first birth among physicians is 30.4. And when we think about why female physicians are having children later, there's a great study out of the GYN oncology department at the University of Minnesota, who administered a survey through the Society of Gynecologic Oncology. This group found that nearly 94% of GYN oncologists delay childbearing due to professional reasons. 67% said that they would have children earlier if they had different jobs, and 22% delayed due to financial reasons. Unfortunately, 13% of participants felt stigmatized for their fertility struggles. And when they looked at when women started to have children, the majority started after their training, which is an indication that many are delaying childbearing due to medical training. In a multi-center survey among trainees in 25 different specialties, the primary reason residents weren't having children was busy work schedule. But lack of childcare, financial concerns, fear of burdening colleagues, and concern for pregnancy complications also played a role. Ultimately, 38% of residents were satisfied with their decision to delay childbearing. And when we talk about delayed childbearing, it's important to remember that fecundability declines with advancing age, peaking in the early 20s and declining more precipitously after age 35. As I mentioned, physicians tend to delay childbearing until their 30s, likely as a result of career pressures and medical education that necessitates training well into the 20s and 30s. It's also important to mention that peak reproductive period coincides with prime career building years, often requiring women to make decisions, sacrificing either their career goals or their family planning goals. Here, I've mapped out my own career pathway. I will graduate medical school at age 26, finish residency when I'm 30, complete my fellowship between the ages of 31 and 33, and start as an attending soon after. These years will be crucial for my own career advancement and professional development, especially as someone who wishes to stay within academic medicine. If I opt to prioritize my career and postpone childbearing until age 35 or after, my chances of successful conception will decline substantially, with a reduced fertility rate of at least 25%. And that's just for one child. What if I want 3? A study from the Journal of Women's Health in 2016 that randomly sampled female physicians from the American Medical Association found that nearly 25% of physicians were diagnosed with infertility. That's compared to about 12% in the general population. This number should be alarming to physicians and medical educators, regardless of their sex or gender. It's also important to note that rates of infertility were higher compared to age-matched cohorts and compared to other professionals that pursue higher educational careers. So there may be other factors contributing to infertility among physicians, in addition to delayed childbearing from long schooling and training. Women in medicine don't just struggle with infertility, but studies have also shown that their pregnancies tend to be more complicated. Female surgeons have double the rate of pregnancy loss compared to the general population, and we're 48% more likely to have major pregnancy complications, such as preeclampsia, cesarean sections, and postpartum depression. These findings were significant even after controlling for age, work hours, in vitro fertilization use, and multiple gestations. The decision to delay childbearing is commonly underinformed, with little understanding of how age relates to infertility. Studies have documented low fertility knowledge among US women and even medical trainees, including a 2018 survey that showed 47% of OB/GYN residents incorrectly believing that fertility begins to decline at age 40. But despite this knowledge gap, little research has been done on the role of medical education in providing trainees with information about age-related fertility decline. Sadly, a substantial proportion of female physicians have regrets about their family building decisions. Nearly 30% would have attempted conception earlier, and 17% would have gone into a different specialty, according to a 2016 study. Overall, 65% reported that their career had somehow influenced their childbearing decisions. And alternately, 70% reported that having children impacted their career. The lack of physician education on the risks and consequences of infertility exacerbates its potential emotional and physical, as well as financial impacts. Those seeking fertility preservation or infertility treatments are at higher risk to experience emotional distress, manifesting as anxiety, guilt, loss of hope, loss of control, or even stigmatization. Particularly for physicians, lack of structured policy and protected time for fertility treatments fosters isolation and guilt within the workplace. Among female physicians, infertility, high-risk pregnancies, and miscarriages have been associated with higher rates of burnout. And evidence suggests that female physicians may already be at higher risk of burnout compared to their male colleagues. And though outside of the scope of today's talk, it is important to recognize that the physical and emotional consequences of infertility may have a profound impact on burnout and overall physician well-being. I would be remiss if I didn't also mention the economic burden of fertility treatments. A single cycle of IVF can cost up to $20,000 if not covered by insurance, with some individuals and couples paying up to $100,000 for multiple cycles. But despite this, coverage is limited. In a sample of 24 US and Canadian institutions, only 66% covered costs related to infertility. Additionally, lack of awareness surrounding infertility and perceived lack of support creates barriers to family building and may contribute to the decision to delay childbearing. In a 2016 survey of residents, 35% reported stigma associated with infertility, and a majority believed that their programs were not supportive of them having children during training. National surveys have also cited unmodified work schedules during pregnancy, inconsistent and brief maternity leave, usually 6 weeks or less, little support for childcare, and little support for lactation needs. A 2016 cross-sectional survey examined attitudes towards pregnancy and parenthood among 66 US general surgery residency program directors. When asked about the effects of parenthood on residents, 61% of program directors reported that becoming a parent negatively affects female trainees' work, including 33% believing that it places an increased burden on fellow residents. They also believed it negatively affected scholarly activities, clinical activities, dedication to patient care, and timeliness. Interestingly, program directors were significantly less likely to say that becoming a parent negatively affects male trainees' work. Similarly, program directors also perceived children as decreasing female residents' well-being more often than male residents. But despite this, the survey also showed programs lack supportive mechanisms, including consistency in parental leave policies, access to childcare, and support for lactation facilities. In a survey of 347 female surgeons, 85% worked an unmodified work schedule during pregnancy, and 63% of which were concerned that their work schedule adversely affected their health or the health of their unborn child. Formal maternity leave policies were reported by 35% of participants, 78% of which received maternity leave of 6 weeks or less, and a large proportion of these residents believed the duration of their leave to be inadequate. 27% had no lactation facilities, and 75% had no childcare support. The same study looked at parental leave and time off after a miscarriage or pregnancy loss. In women who had a pregnancy loss at less than 10 weeks, 80% received no time off. In women who had a 10 to 20 week loss, over 60% received no days off afterwards. And though only a small proportion of participants had a loss greater than 20 weeks, almost 20% of them took no time off. From the data I've shown you, we know that gender disparities still exist in academic medicine. Female physicians tend to delay childbearing and have high rates of infertility, more than 2 times that of the general population. Despite this, training programs are not supportive of pregnancy and parenthood, with little support from leadership and peers, poor scheduling and leave policies, and limited insurance coverage for infertility and fertility preservation. However, we need more comprehensive data from a large national study to further understand patterns of infertility and delayed childbearing among women in medicine. There's also lack of recent data on physician knowledge of the role of age in fertility. We must also understand the ways in which women are changing their career paths to accommodate family building. And finally, there is little existing literature on using egg freezing as a tool to shift peak fertility to a later age and potentially combat high rates of infertility among physicians. We wanted to study this and got a grant to take a deeper dive into these issues and further flesh out the challenges women in medicine face in terms of fertility and family building. The aims of our research were to first qualitatively assess fertility knowledge and family building concerns among female physicians. Second, we developed a survey instrument to characterize the unique needs of women in medicine surrounding fertility and family planning, and to evaluate how these needs may impact career trajectory. And lastly, we hope to determine the cost effectiveness of planned egg freezing as a strategy for delayed childbearing. Briefly, we began with qualitative interviews among 16 female physicians to evaluate fertility and family building concerns. We conducted thematic analysis of the transcripts from 32 hours of interviews, which was used to develop a pilot survey, which was distributed and validated among a small cohort. The purpose of this was to create a tailored national survey that would be administered across the country. And I'm going to review all phases of this research, but it is important to note that our findings from the qualitative interviews with 16 physicians in the pilot survey responses from 24 respondents held true in our national survey of 1,136 responses. Interviews included open-ended questions assessing participants' knowledge of age-related fertility decline, sources of fertility knowledge, and recommendations for improving medical education. Participants were also asked about their intentions for parenthood, their desired family size, and considerations regarding the timing of childbearing. We also hope to learn more about women's experiences with fertility, pregnancy, and parenting, as well as mechanisms of support inside and outside of the workplace. Interview questions also inquired about knowledge of the effects of age on the success of assisted reproductive technologies and influence of fertility concerns on career decisions. Each interview transcript was qualitatively coded by team members to identify common themes and subthemes. Interviews revealed 3 themes surrounding fertility knowledge. First, there was inadequate formal education. All women who participated in the qualitative interviews believed that their medical education on the role of age in fertility was insufficient. All but one participant cited briefly learning about the role of age in fertility in medical school, with one participant stating that she was never formally introduced to the topic during her medical training. One woman stated, "I would say a lot of what we learned in medical school is what I would call outdated. We certainly had no instruction whatsoever on family planning." Second, there was a reliance on informal sources. Participants reported learning about fertility through witnessing the infertility experiences of their patients, their peers, and even through their own struggles. One woman stated, "I was able to feel very supported because a lot of my colleagues are very open about what they've been through with miscarriage, infertility, and pregnancy." And lastly, participants stressed the need to improve medical education. They recommended having frank discussions with trainees about fertility and family planning considerations, as well as their available options, including parental leave, fertility preservation benefits, and infertility coverage. They also suggested education early on in training, including in medical school, with one woman stating, medical school is when people are still considering different fields. To have that information ahead of time would have been good. Within fertility and family building concerns, interviews also revealed 3 themes. First, participants felt career-related pressure to delay childbearing. One woman stated, I still feel like there's a lot of pressure to wait, and that this is your time for training. That stuff could be done later. A majority of participants cited barriers in their training and work environment as the primary reason for delay. Second, participants discussed insufficient mechanisms of support, including workplace culture and policies. One participant commented on this, stating, a culture of constant self-sacrifice, like coming back to work early after not taking the full maternity leave. And finally, interviews demonstrated that family planning affected career trajectory. Women who experienced stressors such as lack of schedule flexibility or social or institutional support were more likely to experience symptoms of burnout, and in some cases considered leaving medicine entirely. Many participants stated that they would reduce their clinical time for additional flexibility for childbearing, considered changing specialties, or leaving medicine altogether to accommodate pregnancy and parenthood. One woman stated, medicine is something I love, but it's not the only thing. If I felt like my current position was taking away from having kids, I'd make accommodations or even leave medicine. We then used the 32 hours of interview data and our thematic analysis to construct a survey instrument. After a panel of psychologists and reproductive endocrinologists assessed the survey for content validity, the survey was pilot tested among 24 physicians. Participants assessed the survey and it was iteratively revised based on their feedback. The findings of both the qualitative interviews and the pilot survey were published last year in JAMA Network Open. The finalized survey instrument included descriptive data on demographics, household responsibilities, and family building and career considerations. We also asked multiple choice questions assessing fertility knowledge. Women were recruited to complete the survey via a national campaign targeting social media groups, residency programs, and academic societies. The following results were from interim analysis of the first 740 responses. We are currently completing final analysis of the total 1,136 responses, and results do appear to be very similar. Chi-squared analyses were used to test the association between fertility knowledge, delayed family building, and infertility, as well as the association between infertility and family building regret. In terms of demographic data, race and ethnicity of our sample closely mirrored that of active physicians, according to 2018 AAMC data. Similarly, sexual orientation mirrored that reported by recent medical school graduates. First, we hope to learn more about participants' understanding of age-related fertility decline. Overall, knowledge was high, with 76% of respondents correctly identifying the age of precipitous fertility decline as 35 years old. We also asked respondents to identify the likelihood of pregnancy per month at certain age ranges. I won't go into too much detail on this data, but importantly, 85% of respondents correctly identified that chances of conception among 43 and 45-year-olds were less than 5%, showing a strong understanding of age-related fertility decline. We also hope to learn about women's understanding of how the success of assisted reproductive technologies are affected by age. Respondents were asked to identify the likelihood of cumulative live birth rate from one IVF cycle for different age groups. Again, these results suggest that respondents generally understood that success of IVF tends to decrease with advancing age, and that IVF is not able to fully overcome the effects of advancing maternal age. Despite knowledge regarding age-related fertility decline, 62% of respondents reported previously delaying childbearing, and 18% reported currently delaying childbearing due to medical training or specialty choice. Among those who had delayed childbearing, 42% had delayed 0 to 3 years, 29% had delayed 3 to 5 years, and 21% had delayed more than 5 years. Knowledge of age-related fertility decline did not decrease the likelihood of delayed childbearing, as there was no significant association between fertility knowledge and years of delaying. As likely a consequence of delaying, greater than 1/3 of all respondents had experienced infertility, which is greater than prior estimates of infertility among female physicians. And among those with infertility, 55% had used IVF to conceive. As suspected, there was an association between years of delayed childbearing and the likelihood of reporting infertility. Women who intentionally delayed family building for 3 years or more were more likely to experience infertility than those who delayed 0 to 3 years. Delayed childbearing and infertility was also associated with family planning regret. When asked in retrospect what they would do differently, 77% of respondents who experienced infertility strongly agreed that they should have tried to conceive earlier, and 78% strongly agreed that they should have pursued egg freezing. Next, we took a deeper dive into the factors affecting women's decision to delay childbearing. The most commonly cited factors were lack of time, lack of schedule flexibility, stress, and concern for burdening colleagues. Interestingly, fewer than 40% of respondents identified lack of partner as the reason for delay. So we know that women in medicine delay childbearing and face infertility, with career factors playing a large part in the timing of family building. We were also interested in knowing how support at home, such as partner support, may be contributing. Respondents were asked about their weekly work hours compared to their partners, and women reported working more hours than their spouse or partner, with over a quarter working at least 60 hours per week. To further evaluate the burden women are shouldering at home, we asked about household maintenance roles, which include things like cleaning, groceries, cooking, and laundry. On average, women stated that they were responsible for a disproportionate amount of these roles relative to their partners. We also asked about family maintenance roles, which include things like childcare, elder care, healthcare appointments, and school forms. Again, women take on a disproportionate amount of these roles. Thus, our data demonstrates that female physicians take on more household and family roles despite working more hours than their partners. Next, we were interested to know how participants made adjustments to their career to accommodate childbearing and parenthood. When asked about extended leave, 20% of the cohort reported taking at least one extended leave of 12 weeks or longer. 21% had chosen a different specialty. 33% had reduced their work hours. 19% had changed their work setting, for example, from academic to private practice. And a staggering 34% had not taken opportunities for career advancement. And while representing a small proportion of the entire cohort, 3% had left medicine entirely. So let's review. Medical training contributes to the decision to delay childbearing and increases the risk of infertility. However, according to our findings, this does not seem to be due to lack of knowledge amongst physicians. Women also work more hours and take on more household responsibilities with little support at home and at work, ultimately leading them to forego career advancement opportunities. To reiterate, over 60% of women in our cohort had delayed childbearing for career and specialty-related reasons. As I explained, fertility peaks in the early 20s and declines more substantially after age 35. But what if we could shift peak fertility to a later age ideally after prime career building years. Full disclosure, egg freezing is not the solution, but it is a way that we can help women achieve their career ambitions as well as their family planning goals. This way, women could ideally freeze their eggs during biologic peak fertility years and then wait until their 30s or even 40s to use them when they are ready to start a family. Part of what our research aimed to demonstrate is that egg freezing is both cost-effective and efficacious for this purpose. One of our wonderful REI fellows here at Northwestern, Jen Backinson, carried out this portion of the study. And I won't go into too much detail on the methods, but we used real-world scenarios from individuals who wanted to have one child or two children using decision tree models. We input data from the Society for Assisted Reproductive Technology Clinical Outcomes Reporting System, or SART, to determine the cost and success rate of these strategies. To obtain one child, egg freezing was more than $30,000 less than IVF, with a 73% success rate. For two children, 2 cycles of egg freezing had the highest likelihood of live birth and the lowest cost compared to all other strategies. Sensitivity analyses show that egg freezing remained cost-effective across a wide range of ages compared to IVF, with the likelihood of success being highest before age 39. Overall, when considering age-related fertility decline, egg freezing at a young age is a cost-effective strategy for delayed reproduction and offers the highest likelihood of achieving more than one child, which is an important and largely under-recognized consideration. So women are caught trying to balance their career and family building with little support at work and at home. Women who navigate fertility, pregnancy, and parenthood are often making sacrifices to their specialty choice and reducing their work hours, which has long-term impacts on earnings and career trajectory. On the other hand, work also impacts a woman's fertility, their experience of pregnancy, their ability to maintain household responsibilities, which women are already disproportionately shouldering the burden for. Delaying childbearing and infertility ultimately affects overall family building goals, including their family size and their desired number of children. In order to balance these responsibilities, our qualitative interviews and survey data revealed that women in medicine approach family building in 3 ways. First, women delay childbearing in order to focus on career, which leads to high rates of infertility and childlessness. Women who begin childbearing early and shift their focus to family are more likely to alter their career and leave academic medicine. In an ideal world, women could prioritize both their career and their family building goals. However, this requires immense familial and partner support, financial support, as well as institutional support. Becoming a doctor, just like being a mother, requires sacrifice, and there's no perfect way to get there. But there are steps that we can take as a medical field to make this juggling act a little less difficult for women. So where do we go from here? A major take-home point from this project is that we need improved reproductive education in medical school. Medical students, residents, and practicing physicians should be made aware of the relatively high incidence of physician infertility, the emotional and financial aspects of fertility workup and management, and options for fertility preservation, including egg and embryo freezing. For example, ACOG and ASRM offer online educational resources regarding the evaluation and management of fertility. These resources could be used as the foundation of fertility education and could be tailored for physicians at all levels of training and practice. Our qualitative findings also showed that female physicians learn about fertility through open conversations with senior colleagues. We can support these kinds of discussions through mentorship by increasing the number of experienced mentors who exhibit successful work-life integration. And finally, increased awareness among institutional leaders in both the clinical and educational spheres may improve empathy and understanding, and ideally promote creation of innovative programs for fertility support. For those who want to have a family now, we should supply the resources for them to do so successfully. Many women report unmodified schedules during pregnancy, despite concerns about fetal and maternal health. Formal policies should provide reasonable work limitations near term and should include appropriate clinical coverage without overburdening other trainees. After birth, we need consistent maternity leave policies across departments and institutions, and urge for increased uniformity for training requirements when leave is taken. And although formal and well-defined policies are helpful, policies also need to allow for flexibility for each individual's needs. We also need to promote leave for both parents in order to dismantle gender roles and unequal expectations for physician mothers. Minimal lactation support and challenges balancing work duties with breastfeeding cause many women to stop breastfeeding earlier than they wished. Practical solutions that minimize disruptions to education and patient care include cross-coverage systems to relieve nursing trainees and designation of facilities with dedicated equipment for expressing and storing milk. And finally, on-site daycare, sick childcare centers, and subsidized programs to support childcare costs have been implemented cost effectively for many businesses, hospital systems, and residency programs. Successful childcare programs have also been found to promote employee wellness and retention. For women who wish to have children later, we need to inform them of their options, including fertility preservation and the risks of infertility with advancing maternal age. Beyond education and awareness, it's critical that physicians and trainees have access to affordable fertility assessment and management. To minimize career about time away from work and possible stigmatization by peers and leadership, time off for fertility evaluations and treatments should be incorporated into routine health maintenance. And although egg freezing is not the answer, it can be a cost-effective strategy to help with deferred reproduction and should be made more widely available and affordable for those in training. Given a majority of our respondents did not cite lack of partner as the primary reason for delaying childbearing, embryo freezing is also a viable method for those who wish to wait to get pregnant. Ideally, all academic and private practice institutions should contract with their insurance providers to offer coverage, not only for fertility treatments, but also for preservation. And in addition to providing insurance coverage, psychological support and time coverage should be provided for those seeking treatment for infertility. For example, institutions should provide financial as well as time support for counseling visits with mental health providers for those struggling with infertility-related anxiety and depression. Institutional sponsored support groups may also be helpful for this. Some pretty famous companies have incredible coverage for infertility, and more are starting to have coverage for fertility preservation. However, it's shocking that few academic medical centers have a similar level of coverage. Northwestern is one institution whose residency programs have adopted comprehensive coverage policies for both fertility treatment and fertility preservation, including egg freezing. However, especially given its efficacy and cost effectiveness, this coverage needs to be more ubiquitous. A new AMA policy passed in October of 2022 encourages insurance coverage for fertility preservation and infertility treatment within health insurance benefits for residents and fellows. Of course, we need buy-in from GME leadership at individual residencies and fellowships, but this policy is a huge call to action and hopefully an instigator for a larger cultural shift. Traditional gender roles and expectations surrounding mothers in the workforce are endemic in medicine. The discrepancy of fewer women in leadership roles also leads to lack of mentorship and role modeling for women entering medicine. Ultimately, culture change starts from the top down, So we need to prioritize promoting women as leaders in academic medicine in order to ever expect change. I would like you all to walk away with an understanding of these key points. Medical training and career-related pressures influence the timing of childbearing. And despite adequate fertility knowledge, female physicians delay childbearing and have high rates of infertility. And for those who decide to start a family early, many make alterations to their career to accommodate family building and parenthood, which ultimately leads to academic attrition and inequity in leadership. Possible solutions include education on the incidence, causes, consequences, and treatment of infertility, access to fertility treatment and preservation, institutional support for flexible scheduling and leave policies, and ultimately a culture change. I also want to reiterate that our language must be inclusive in conversations of fertility and family concerns to include transgender physicians, single physicians, and physicians with same-sex partners. I want to say a huge thank you to Northwestern Medicine Center for Fertility and Reproductive Medicine, as well as our incredible research team. And a special shout out to Dr. Feinberg for helping me with this presentation and being here today and being an incredible mentor over the past 4 years. I will take any questions at this time.